complexity has never been more true than it is today. Across the week, you've heard of an array of dynamics that are going on in 2025 that impact the complexity of our marketplace. And I'll focus on just a couple of those as we get started. The first is the reimbursement landscape. It's never been more complicated, and there's never been more pressure from all directions. Generics we're seeing a reduction in volume of generics with MFP. We're certainly seeing growth in brands, but with the growth in brand volume, we're also seeing a decrease in reimbursement with AWP minus 22.5 in the year 2025. We also continue to see management pressure that comes at the cost of administrative burden. As we see the specialty, the brand marketplace increasing, a lot of that increase is coming from the specialty marketplace. You might be surprised to hear that in 2023, 80% of the drugs approved by the FDA were in the specialty category, and they now account for 56+% of pharmacy spend. It also probably will not surprise you that along with the growth in the specialty marketplace comes a growth in the types of specialty models that are out there, including increases in health system-owned SPs. Some reports suggest that up to 80% of the largest health systems now own their own SPs. Certainly that brings a new dynamic to the marketplace, as well as some very real positives to the marketplace. And finally, innovation is changing the way we think about medicine going forward. The speed of diagnosis, the accuracy of diagnosis, these types of things are improvements in our marketplace, but they bring complexities. So complexity is not going away. It is the name of the game. And what that means is we have to change our strategies and be very intentional about the types of channel approaches we put in place as we think about launching products in the marketplace going forward. With that in mind, it's my pleasure to introduce to you our panel today. So starting to my right here, we have Troy Shirley, who is the System Director of Pharmacy at Bronson Healthcare, headquartered in Kalamazoo, Michigan. Troy brings us over 25 years of healthcare leadership experience in various size ends. Troy has strategic and operational oversight over the entirety of the pharmacy enterprise at Bronson, and in his current position, implemented a robust health system-owned specialty pharmacy that has operated in this space for about 8 years. To his right, we have Susan Faust, Chief Strategy Officer of Solio Health, where she leads pharmacy, payer, and provider divisions. She brings over 35 years of healthcare experience, including specialty pharmacy, PBM, home infusion, and home health. Then to her right, we are pleased to have David Condrick, who we like to refer to as DC. DC comes to us from Nuvations Bio. He brings over 30 years of industry experience. He launched the first limited distribution network at Pharmacyclics, and he likes for everyone to know that he attended the University of Pittsburgh School of Pharmacy, LPIT. And then, last but not least, to his right, my colleague, Kim Klein, who is the General Manager of Channel Strategy at Atari. Kim's background in specialty pharmacy is in specialty pharmacy. She's been on the consulting side now for the past 6 years. She focuses on commercialization strategies, supporting first-time launch clients. She has supported over 60 drug launches in a variety of capacities over the last 15 years, and we're happy to have all of you on our panel today. As we get started, we want to just ground our discussion in a couple of scenarios. I will point out that these scenarios may seem familiar to you based on drugs you know of in the marketplace. Neither of these scenarios are exactly a product that is in the market or exactly like a product that is coming to market, but they do take some inspiration from products like that. The first is in the cardiology category. Think of it as a high-risk specialty managed indication. Think of it as an RNA-based long-acting self-injectable, indicated or initiated typically in the outpatient setting, post-hospitalization typically. It's high cost. It does have direct competitors in the market and emerging therapies on the horizon. And let's say that the payer mix is about 1/3 commercial and about 2/3 Medicare. The second product that we'll consider as we go into our discussion in just a moment is the immunology category. This particular product, I think this is a rare disease chronic use medication, available in a self-injectable formula as well as an infused formulation, initiated in the outpatient setting, typically in an infusion clinic, post-hospitalization, as I said. Again, high cost. There are direct competitors on the market or on the horizon. Nothing currently in the market, though mechanisms of actions that exist in the marketplace are used off-label in this disease state today. And the payer mix here is the opposite of the previous scenario, with about a 2/3 commercial and 1/3 Medicare mix. So with these scenarios in mind, I'd like to start with you and ask, as a consultant, how did you start the process of defining channel strategy when you sit down with your clients?
Thanks, Andrea. Great question. And really, in most channel strategies, when manufacturers start the process, it is done in collaboration with consultants. For me, working with my clients, I really start the process by ensuring I'm focused on two areas to start with, and that's the target product profile, the attributes of the product, and the patient journey. And that involves completing comprehensive market research to really understand that patient journey in complete totality. There are many different nuances to consider, but I've found starting with these two areas really helps set the stage and ground us as we start the channel strategy process. I have two main goals that I look at when I start working on a channel strategy, and that's to make sure that we're getting patients on therapy as quickly as possible, and they have the patient support services in place to help them stay adherent as prescribed.
Fantastic. DC, when you approach channel strategy from a manufacturer perspective, what motivations guide your decision making?
From a manufacturer perspective, two main things. First of all, patient focus and managing the patient journey. And I'll give you an example. Past several years, I've been in the oral oncolytic space, and we'll use the example of a Medicare patient. My experience has been for that particular patient, the IDN setting is the best journey for the patient. So you have an individual who never received a specialty drug before, gets a agent for oral oncolytic. They have no idea about copay mitigation, whatever. That hands-on, in-person experience seems to be the best journey for that patient. And a lot of these individuals like to pick up their drug in person versus someone getting a call on the phone and asking for their social security number or their credit card. So that's a partner that you want to look, and it's different for every particular drug out there. There's no one basically best scenario for each particular drug. But this is all based on the fact that whatever entity that you partner with for that patient journey has the necessary infrastructure to provide those services to that particular patient. For the IDN in particular, for this situation, they have all the information, they have the financial, they have the testing, they have all that. And that journey will determine then how the patient experience goes and basically the final outcome, which you want it to be very beneficial for the patient and their family.
And DC, just to continue your line of thinking there for a moment, how do you think differently about channel strategy for a rare disease product versus a more common but high-risk?
Yeah, that's a great question because every drug is unique. Number one, you look at the age of the patient. If it's a high-touch pediatric drug, I think anyone who is a parent here realizes that Children's Hospital would probably do the best job in that particular situation. But if you even look at something that's a worldwide, very ultra-rare disease, you have to have a partner that has a bevy of services, language, someone who's going to pick up the phone 24/7, very high touch. So that is a very special partner. But getting back to patients that are common high-risk conditions for adults or children, like an anti-TNF or even the growth hormone space. As a manufacturer, you're looking for a partner that has very good analytics. From the standpoint of time to fill, how quickly they get to the patient. And the second part is analytics, that you want to know exactly when the patient's getting it, what that data feed is, communication, different things like that. And then I think we'll also talk about hub services And you don't want someone walking out with a $1,000 copay. So you want to make sure that whatever hub services that your partner has, making sure that they have the necessary educational, financial, and other patient services to make that journey as beneficial for them and their family as possible.
Fantastic. Susan, if I could turn to you for a second. As a specialty pharmacy expert, what key concerns should we consider when developing channel strategy for each of these scenarios?
Thanks, Andrea. And in both of these scenarios, there are some commonalities, so I'm going to address those. And the first thing is you're going to hear a lot from us about the patient, because for you in the audience and for us on the panel, it truly is all about the patient. So one of the concerns that we talk to our manufacturer partners about is definitely the cost. And what is the cost to that particular patient, their out-of-pocket cost? And is there foundation help or other help to mitigate that cost? If the cost is too high, and you've seen this and we've seen this, the patient either doesn't start on service or they are not adherent and compliant with their medication. You have to meet the patient where the patient is. And C talked about the IDN, which definitely is a solution. You're looking for a specialty pharmacy partner that hopefully has omni-channel. In other words, they can do things in the home if that is appropriate. They have sites of care. There's also white bagging into the physician's office. Again, you and we want to make sure that the patient gets their medication in a timely manner and where it is best from a clinical as well as just a situational perspective for that patient. Then we come down to the payer. You have to get paid for these products. And we talk to our pharma manufacturers about what's the attribute of this patient? The medication. Where is it going to be paid? Is it going to be on the pharmacy side? Is it going to be on the medical side? And sometimes, as you well know, it's both. Does the specialty pharmacy, are they covered for all of those scenarios? What about Med D, and what about Medicare Part B? Is that a resource that they have? It costs a lot of money to bring a product to market. So when you are looking at services, specialty pharmacy services, hub services, and anything else that you might want, take a look at the goal of each of those services. And then choose the entity that is best equipped to provide those services. Example, hub services are great. They're wonderful as far as getting patient consent, patient training, nurse navigators, and foundation help. However, on the other side of the fence, when you're talking about dealing with the insurance company and talking about prior auths and benefits verification and benefits investigation and all of the things that go into that, your specialty pharmacy is going to have to do it anyway. Maybe you can save some administrative costs by looking at services individually and then deciding which entity has the expertise and resources for that. And then, what are competitors doing? Are you looking at the competitive landscape as you're launching your product? And what does that tell you? It may tell you a lot and it may not tell you anything at all. So I would be sure to look at that and get the information about a competitive product if there is one, but also talk to your consultant and talk to your specialty pharmacies, your IDNs, all the people that you are looking at from a channel perspective, and get their experience in what works and in what fails. I was involved with a manufacturer once who absolutely positively thought, absolutely, this was going to be a buy and bill drug, by gosh, and that was the channel that they chose. Guess what? It was an ultimate failure because they forgot that the patients were debilitated, that it did not work for them to always go into the doctor's office. So home care and AISs were, also a part of it. They pivoted, but they pivoted post-launch. Make sure that you gather the information that you need in order to make those decisions. So those are pretty much my concerns.
Thank you. And Troy, as we round out sort of general considerations, I'd love to know from your point of view as a health system-owned SP, what are the key considerations for each scenario, and how do you align, how are you unique in your SP capabilities as a health system?
Thanks for that question. You know, looking at these two scenarios, the first thing that pops into my brain is access and then secondarily affordability. Whether that access blockout is from the manufacturer with limited distribution, whether it's from the payer with not being in network, that can become problematic for our patients. Then I look at the immunology therapy specifically, and to DC's point, probably a pediatric thing, probably best served by going to a pediatric specialty center. However, for some of those patients, it's a long way to travel to see their care. And if we're asking them to make that journey multiple times a year, it becomes highly inconvenient. So if we can take those key elements of it and train our local team to be experts in that therapy and provide that treatment locally, it's certainly helpful to aid in adherence with the patient. Looking at your two scenarios here as well, the affordability pops in, the cardiology drug being higher Medicare, you know, there's not a lot of options available to offset the copays. On the commercial one, for the immunology one, though, I'm actually less concerned about affordability for those patients because with the commercial payers, we have much more broad access to patient assistance programs and copay assistance programs. Now, where do I think the health system-owned specialty pharmacy is unique or different? As we talk about the different sites of care, we have all those sites of care. And there's other specialty pharmacies that have those sites of care, but we have them. If it starts in a hospital-based infusion, moves to home and ambulatory, moves to a physician office setting, moves to self-injectable in the home, we have all those sites, and we can easily transition and move the patient through those sites very seamlessly. On top of that, we have the tight integration with the medical record. So our pharmacy team can easily communicate with the provider team and can easily communicate electronically with the patient. And so everybody providing care to that patient has very clean line of sight into any barriers to treatment, any adherence issues, any side effects, and we break down the fragmentation that happens sometimes.
Thank you. Let's dig in a little bit deeper, and Susan, I'll start with you and ask you this question, but then ask you to pass out to DC, and DC, if you'll pass to Troy. From your differing perspectives, what SP services are critical for each of these scenarios, and how do you align those with health services that are sometimes provided?
Right, so what you have to do is look at the attributes of the drug, and you're, in both of these, if you're launching either the cardiology drug or the immunology drug, you're gonna have an RFP, and what I would do is, your teams have created what you believe is the ideal patient journey. This is your baby. In your RFPs, what you need to do is take a look at the resources and the assets of the specialty pharmacy that match that patient journey and how they can fulfill clinical, financial, payer, all of those needs. In both cases, there might be some nursing involved and some nurse training, especially in the immunology, as that's going to start out as IV. What is their nursing capabilities, and are they using outside agencies, or do they have their own nurses? Do they employ their own nurses that are going to be a nice fit and do a lot of collaboration with the pharmacy? What does the pharmacy team look like? Do they have the expertise? Do they have a team that are experts in cardiology and experts in immunology? So not all entities are the same. And definitely, specialty pharmacies have their different focuses. So choose the one that fits the attributes of your drug. Site of care, again, meet the patient where the patient is. Is it home care? Is it physician office? Is it an AIS or anything else? Make sure that the specialty pharmacy is able to meet those needs. And then, what are the prescriber relationships like? How are they going to make sure that when your drug comes down and the prescriber sends the prescription to a pharmacy, is that prescriber confident that that pharmacy and the pharmacists that work there and the pharmacy techs and the nurses have the expertise to assist that patient and to give that data back to give that information back to the prescriber? And last but certainly not least, what are your data requirements and how well can the specialty pharmacy make sure that that data is returned daily, hourly, weekly, monthly, so that you have all the information that you need about this drug that you just launched. So I think those are the most important things from a specialty pharmacy perspective. Oh, I forgot this.
No problem, no problem. Just Carol, what Sue's saying, from a manufacturer standpoint, we all sit together and we say, okay, this is what we want to do for the patient journey. So you have to find a partner that is going to execute that strategy for you. And it could be home health, IDN, SP, whatever the case may be. The challenge and the opportunity comes into the fact that you have to basically follow the life cycle of the drug and the patient. Case in point, when you first launch a drug, there's going to be payers in particular. They're not going to have a policy. So the free drug program is a very, very important part of getting patients on drug as quickly as possible. As you move towards having PA policies per your label and so forth, that's going to diminish. But for your commercial patients, constantly, you want to make sure that drug is being sent out. They're not going to, again, they have a copay of $1,000. So you want to use your copay mitigation services. And part of that relationship with the hub or whatever is basically the intertwining and communicating of those services between your ideas and what your partner can provide. I'm going off this a little bit off the beaten path here, but one of the challenges that comes into play is that you have an idea what a utopia is, but in reality, they cannot execute that. So that's the challenge and the opportunity of the relationship, but it's constant communication, so forth. So, President Troy.
Yeah, I'll build on that. Thank you for that. Thinking of the hub, I think in isolation, the hub sounds wonderful.
Yeah.
The patient has a resource that your company is providing to help navigate the patient through that journey. However, where we see it from our end is it can be duplicative, redundant, actually confusing to the patient. Our program is set up highly functional, and other programs are similar to that within health systems with either a pharmacist or a pharmacy technician or another resource in that prescriber's office, handling most of those things for the patient. And so when we connect them with your hub services, because the financial assistance programs are wonderful with copay cards, then they get portaled into your entire hub service, and now they have a random nurse calling or a random somebody else coming, and it becomes very confusing to the patient. And I look at these two scenarios. On the cardiology side, we'll stereotype older people in this situation, and they've got the doctor's office calling, the pharmacy calling, now the hub is calling somebody that they don't know. Or even on the immunology side, and we'll assume that maybe this is a kid, and the parents may not be super health literate in navigating through it, and it just adds another layer of complexity and confusion. So make sure as you roll out your products, you're very well in tune with the organizations that you're working for, the prescriber offices that you're really targeting for those medications, and understand the support structure that they're using. Do they have a health system-owned specialty pharmacy with all these resources, or do they not? And in that scenario, the hub becomes massively important.
Thank you. Daisy, I'm going to ask you to shift our focus just for a moment and talk about distribution strategy. What are the critical considerations for each one of these scenarios as you think about distribution strategy?
Great question. What you mentioned, we're at Pharmacyclics. We're one of the first companies to come up with a limited distribution network, and it's really changed significantly since those past, I think, about 12 years. First of all, whatever organization you're going to partner with, either a IDN, integrated dispensing, independent SP, whoever it is, you got to make sure they're patient-centric. And as a manufacturer, your job is to identify that, making sure that they are. And I think if you meet with someone for a half hour with their presentation, you can tell if that's the case. Another thing too, and this is something very important, especially at this meeting, is what is the SP footprint? So there are entities out here in our meeting this week that are really great in like neurology, but they have no footprint in oncology. But you're launching a oral oncolytic agent, they'd have no footprint in these community oncology or the Mayo clinics, whatever. Probably not a good partner. But you may have a business development person who is meeting with you, and once again in oncology, it's probably not a good collaboration at the beginning. A question I get a lot is, you kind of preference for IDN, is it IDN only, is it SP only? Actually, the answer I think is a combination of both. You need both entities. First of all, if you have a whole age worth of patients, IDNs and standalone SPs offer different opportunities and services which complement each other. And I'll go back to what Troy was saying. You may have a great IDN service and partner, but they don't have a letter of agreement with a particular payer. So patient needs to get the drug. So they have to go to one of the independent SPs. So they need to work together, and you need both of them in your network. Can't be an exclusion one or the other. And then the last thing is, I think you look at past products that your partner is looking to provide services for. How happy is the other entities that they're partnered with? And there's a little homework on your part as a manufacturer to do that due diligence. And I think if you do a lot of that stuff, you'll come up with a pretty good network.
Thank you. To ensure that we're holistic here, I want to take a second and consider the payer. And I'm going to ask, in the interest of time, for some brief statements, Troy and Susan, regarding the role of the payer. So, Troy, if I can start with you, and we'll transition over to Susan.
Yeah, certainly access. Again, I touched on it with the distribution channel for manufacturers. Same thing with the payer. We need to be in networks so we can provide that care to our patients. We have metrics. A lot of health system-owned specialty pharmacies have identical metrics that we get patients on treatment faster through our pharmacies. We have higher adherence rates. We break down those financial barriers. When we're locked out of the payer networks, it becomes frustrating as the provider for the patients in the center where we're not able to provide them optimal care. The other piece that is extremely difficult to navigate the patient through the journey with the payers are the white bagging scenarios, where the patient's drug needs to be infused, but it's covered under the pharmacy benefit. Again, it sounds great on paper. If anybody's experienced that as a patient or a family member, you know it is one of the most disruptive scenarios out there. So to the extent that you can work with your payers to develop those networks, steer clear of white bagging and make sure the right pharmacies are in the network. Susan?
Thank you. To tag on to Troy, definitely when you're looking at your specialty pharmacies, you want depth and breadth of contracts, not only on the medical side, but on the pharmacy side, because in either of these scenarios, they could be covered under either or both. So make sure that they have that. But I would dig deeper and talk to them about their payer relations. Do they have special programs within different fields? We talked about, hey, not every pharmacy does oncology well, not every pharmacy does neurology well. Find out where their expertise is and where they have those relationships with specific programs with payers, because it happens all the time. Then, if you're looking at the life cycle of a drug, and let's take the immunology one again, and you're starting out as IV, and then maybe you're going to a clinically administered sub-Q, and then a self-administered, and maybe even an oral, make sure that your specialty pharmacy can make that journey. But let me tell you something. When it switches from the medical benefit to the pharmacy benefit, the financials change dramatically for the specialty pharmacy, and not in a good way. So be sure you talk to your entities, to your channel partners, about the life cycle, and not only from a service perspective, but also from a financial perspective. So that's the payer story.
Thank you. Kim, we started with you and with thinking about the launch of a product, and so I want to come back to you to round out our discussion today. And let's again refocus ourselves on the patient. How would you just continue your discussion with the client to think about all of this whole context of content we just talked about in the development of their channel strategy?
Perfect. Thanks, Andrea. And this has been a really good discussion. We have a very diverse panel for that reason. And as you guys probably heard, there's not one way to optimize your channel. There's many different ways to approach it and get the product in the patient's hands. And we wanted to leave you guys with a checklist to think about as you're approaching your channel strategy. And this will be posted on the Asembia website as well. But it's important to think about, the therapeutic area you're entering. DC, I'd mentioned like oncology, for example, and the roles IDNs play, or immunology products that are infused and the roles that maybe in-home infusions may play in that. So that therapeutic area is going to be really important because each therapeutic area has its own nuances that you're going to want to consider. In addition, we talked a lot about the patient journey. The patient journey is extremely important. Making sure you're doing your market research ahead of time and understanding what that patient has experienced, and it goes beyond the patient sometimes with the caregivers that might be involved as well. And ultimately, you want to make it as seamless for the patient as possible. There's also things like the patient population size and demographics that are going to play a role. Are you looking at a rare disease and trying to find access for 5,000 patients or 500,000 patients? And what does your channel look like based off the amount of patients that you may have that would be on therapy? Is this a younger patient population? Are we looking in the pediatric space? Are they more engaged in technology, and what could the role of technology play through that channel? Or is it an older population that may be relying on long-term care for access? The other things you're going to want to look at are route of administration. Will a HCP be administering this product, or is it a product that the patient can take at home? Is there competition in this space? Analogs are something you want to look at, but they're not the be-all, end-all. Maybe there's a similar product out there, and what can you learn from it? Were there things that you could improve upon, or things that they did really well? And maybe the competition doesn't exist yet, but it's in the future. So how do you consider the other products that may be entering this space as well? Also, resources and economics. Some of these companies are launching their first drug. They may not have a lot of funding. They may not have a lot of people resources to help manage that network. You have to think about that and the implications that could happen there. And lastly, cost of medications. That is something to consider. It's not the most important by any means, but is this a $3 million product, or is it a $500 therapy? So thinking through the costs of that therapy is also going to be important. The last thing I'm just going to leave you on is there is no right or wrong answer, but the main thing that was the underlying theme here is making sure that we're considering the patient as we're looking to optimize that network. I want to thank the panel, first of all, for coming up here, but we do have a couple minutes. If anyone has any questions, feel free to stand up, and when you do, speak loudly and please introduce yourself.
Any questions? We have about 5 minutes available for questions if they're out there.
Looks like we might have answered them all, Andrea.
With that, thank you very much for spending time with us this morning. Thank you to our panel. We appreciate you being here with us and lending your expertise.